Yeah.
We're live in 5, 4, 3, 2, 1. We're live.
Yeah. Good evening, everybody, and the warm welcome to Professor Hemant Sharma, sir, from UK. In this ASAMICON curtain raiser webinar. Before we start, I'll just give a brief introduction of our speaker today. Professor Hemant Sharma is a leading consultant trauma and orthopedic surgeon based in Hull, UK. He has a special interest in lower limb surgery, particularly of hip, knee, and limb reconstruction. Correction here, he is president of British Limb Reconstruction Society. Professor Sharma had his initial training in Gwalior, India, and further training in Newcastle and then Yorkshire. He underwent training for hip, knee arthroplasty as well as foot and ankle surgery, and did his limb reconstruction fellowship from Belfast and Italy. He is an avid teacher and researcher who travels extensively within the UK and internationally, delivering lectures at various courses. He also runs internationally renowned deformity course at Hull. He is honorary professor in trauma and orthopedics at Hull York Medical School University. He is consultant trauma orthopedic surgeon at Hull University, and he has more than 50 publications. He has won Best Poster Award in 2019, Best Paper in 2015, and another Best Paper in 2011. All these are on the circular frame and wire placements of Ilizro. I welcome Dr. Sharma for his talk on external fixator assisted internal fixation. Over to you, sir.
Jayant, thank you so much for such a good introduction, and that's very kind and generous of you. So thank you so much. Let me just share my screen. So Hull is a place in north of England at the bridge of, at the mouth of River Humber, and quite strategically located for trade, and that is perhaps the reason that after the establishment of town very early on in 13th century, in 12th century, very quickly it was realized that it is a town which is important for trade, especially for Scandinavia and the east side, and therefore King awarded the city. In those days, it used to be the King will award the markets. So the two markets were awarded, and then King also named the town. He used to call up Kingstown upon Hull, and from there, originally the name is known as Kingston upon Hull now. So that's how the name came about. This is a church which was built in 1285, and it still stands, an amazingly beautiful church. And this is part of one of the things about Hull. The other thing about Hull is the bridge is almost 2 miles long. It used to be the longest single-span bridge in the world, and now it's the third longest. But it is one of the iconic things about Hull. And there's a lot of things, so I won't go into everything. And if I'm sure you must have read Robinson Crusoe, and in fact, he set sail from Queen's Dock in Hull in the book by Daniel Defoe in 1651. So even in the fictional characters and adventures, Hull was well recognized. From hospital point of view, it's a very, very old hospital, but I think more than 200 years old. But I think the current hospital is fairly new, and we have two large hospitals, total 1,500 beds. We are a university teaching hospital. We have our own medical school, and it's quite well. And we are the regional trauma center and the regional center for all the specialties across the specialties. And this is a big Queen's as an oncology center, massive 300 million pound oncology center. Apart from orthopedics, unfortunately, it does everything else. The other interesting story you might be interested in is in that a long time ago in 1856, the chap used to call Thomas Smith, and he started selling various stuff to hospital, including bandages, cod liver oil, and he was quite successful. And when in 1897 his business grew so much, so he asked his nephew to join him. And this is how the company Smith & Nephew was formed in Hull in 1897. They're still based in Hull, although the orthopedic division has moved to Memphis in US, but the wound division is still based in Hull, and all the dressings you see in the world are all made in Hull. So next time you use a dressing from Smith & Nephew, please remember Hull and remember us. Of all the people, the most famous son of Hull is William Wilberforce. He was a member of parliament from Hull and York, and he fought all his life against the slavery. And because of his efforts, and there are a few others, was not the only one. Initially, the British Empire passed the Slave Trade Act and stopped trading in it. And his continuous effort in nearing his death around about that time, they actually passed a Slavery Abolition Act. And because of their efforts, the slavery was abolished in the entire British Empire. And that was, he was the member of parliament from Hull. And recently, we celebrated 150th anniversary of William Wilberforce. My name is Hemant Sharma. I work in Hull, as you must have realized by now. And I run a tertiary limb reconstruction and bone infection unit in Hull, and 90% of my work is limb reconstruction. And I've been asked to talk about external fixator and navigate. Well, I've added navigated. I thought it would be important to introduce that. Basically, external fixation assisted deformity correction and internal fixation. My email address is below, so if anybody wants to talk to me about anything, about any queries or concerns, please feel free to do so. So in this next half an hour or so, I expect that I'll introduce we will discuss the basics about the topic. We revise the osteotomy rules. We do look about the surgery techniques, corrections in brief, and bit about autoplating and nailing and some tips and tricks along the way I should be able to give to you during this talk. So the question then comes in, why we use internal fixation? Well, the most important thing is it's easy for the patient. And so patient don't feel the pain, the discomfort, the muscles don't move around the wires. And particularly for femur, it's perfect because patients struggle with the femoral frame. And we have all slowly going away from the femoral frames, and I have done a femoral frame in the last 5 years or so. Very rarely I do it. There are indications, but they're very, very few now. And the other advantage of that is that we can individualize the treatment. We need to consider the patient factors and the deformity factors, and depending on that, we can individualize the treatment for the patient. So that's another advantage. And this is an example of sort of elderly lady, well, just beginning of elderly, because 65 is when the age of elderly starts in UK. Quite severe lateral compartment OA, couldn't walk, and the knee surgeons weren't keen to do a knee replacement. And she couldn't have tolerated frame, no way. And we couldn't want to, I don't want to put the frame in the femur anyway. So all you need to do is put in a fixator assisted internal fixation, and you get the axis quite straight on, and then and she's happy, she's pain-free after 3 years. She will need a knee replacement, there's no doubt about it. But when she gets it, it will be standard knee replacement, and the longevity would be as any other knee replacement. Now the question then comes in: how do we improve the accuracy of the correction? So the help of the fixator is pretty good, because we can correct it, check it, and then put our internal device. In addition, I also use computer navigation to help me as well. Now, there is no purpose-built platform, so you can use any Total Knee or HTO software with any of the Total Knee companies, and because it only provides the mechanical accuracy, and which is actually what we are looking for in these things. The other thing is, if you're not sure and we want that we need to really absolutely accurate in certain situations, then what we can do is we can do a two-stage procedure. And what it does is it gives you best of the both. So stage one, you correct the deformity, put in a circular frame, and 4 to 6 weeks later, when this is all corrected, you go back, put in an internal fixation, and remove the X-fix. The advantage is that it's most accurate, and it addresses the static and the dynamic deformities both, which is the best thing we can do, because taking into consideration dynamic deformities can be a little bit challenging at times. The only disadvantage is you have to have 2 surgeries, and the infection rate can be a little bit higher, although there's no evidence, but logically it is a risk. Now before we do anything, there are a number of factors we need to consider what we're going to do there. And there are a lot of things we need to consider before we decide age and deformities and how best you can do things and what you're familiar with. Do we do lengthening, all kind of thing. But especially we need to consider the soft tissue, the hardware we're going to use, because it is quite important we do plan accordingly, and the vascularity and the previous surgery patients that has had. So that will determine where the osteotomy you're going to use, and is very, very critical. You need to consider where you're going to translate. If there is a translation, you need to take into consideration, otherwise your fixation device, you might be in difficulty on the table. And whether it is a single level or a multiple level correction you're going to do. This is all you know, so I'm going to just skip through it very quickly. You have an opening wedge osteotomy, you have a closing wedge osteotomy where you lose the length, and you have a dome osteotomy. So I'm not going to talk about this because it's quite obvious, you know all about this. But I will mention translation because this is quite important. Frequently you'll find that your cora is at the junction where your fixation will become difficult if you use the cora as your osteotomy. So you have to move your osteotomy away from your cora, and which basically means you end up using rule 2, and there's an obligatory translation into your surgery, and this has to be taken into account. And in this case, if you see your cora is very low, if you use the osteotomy here, you wouldn't have enough space for the fixation. It's a bit low actually, down over here, and you very small space for fixation. And if you go too low, you might compromise the PCL attachment. So what you have to do is you have to put your osteotomy higher and translate. But you need to take that into consideration and ensure that when you translate, the device you're going to use that has to compensate that. So this is quite important to plan that. The other thing we all must be familiar is the osteotomy rules. And I think it's not a bad idea to do a quick revision about it. Now, when we're doing any corrections, where we do the correction, that is ACA. And ACA is what correction is done, and this can be different from the osteotomy site or the cora, we all know that. And this is typically where you have put your hinge in Ilazarov frame. Now, you don't have to have a hinge. You can do it various other ways. You could use a virtual hinge. That's not an issue, but it is where you're doing the correction that is important. That's your ACA, which need to, and that needs to be considered when you're doing any corrections. So what is osteotomy rule 1? When your ACA, your cora, and your osteotomy is at the same level, So when you correct, it corrects without any translation, and your proximal and distal segment becomes collinear and straight. And this is an example that is corrected with no secondary translation. So the advantage of this is that since there's no translation, you can use any implant. You can use a nail, plate, fixator, whatever you want. Fixator you can use with anything, but a nail and plate you can use easily, and that's the advantage. Osteotomy rule 2, when ECA is through the cora, but osteotomy is away. So what happens is that it's corrected. The two segments are collinear, but there's a slight translation. So there's a bone becomes slightly zigzag. The disadvantage of that is that you can't use every implant. And this is a good example. So if you plan your osteotomy here, your cora is really high, and you can't really use any implant. Even the circular frame you can't use if you do an osteotomy at cora. So you have to move your osteotomy down. When you move your osteotomy down, it becomes rule 2, and you correct here at your cora, but it automatically translates and gives you rule 2, and that what it does, your axis becomes straight and the angle becomes normal. So this is quite important for periarticular deformities. The downside is the implant choice may be limited because of the translation involved in it, and at certain places it may not be suitable for nail, and that's the reason pre-planning is critical. But it's excellent for the periarticular short segments around the joints. And when you have a compromised soft tissue where you want to move your osteotomy, even though you can do rule 1, but the soft tissue is bad, so you'll rather use somewhere else to do your osteotomy in a good tissue and good bone to ensure good healing, and then you have to use the rule 2. Rule 3 is when your osteotomy and ECA both are away from the cora, and therefore which means it results in a secondary translation. Now, actually, this means we have created a deformity. In the process of correcting one deformity, we've created a secondary deformity. Now, this you can use to your advantage. If you have already pre-existing translation, you can use a hinge in a certain way, so it corrects, so you can use it. But I think understanding of this is important because A, not to create the deformity, and B, if this is a pre-existing deformity, you can use to your advantage, but often it is a mistake, and therefore we need to plan it and ensure that we understand the rules well, so there is no situation where you end up with a secondary deformity. The other issue is when you do an acute correction is the soft tissue, because you're acutely correcting the soft tissue, and which means that your neurovascular structures would be stretched. So depending where you're doing your deformity, how far is the neurovascular structure, how well this is contracted through the fascia, through the previous scar tissue, patient had previous surgery, how much you're going to stretch, and there is no rule for it. We can all do the calculations and plan it out, but in actual situation, there is no way you can predict it. And all these calculations, I must emphasize, are for normal tissue. But if somebody had a previous surgery, the stretching of the tissue is very different. So let's say the most common example, the common peroneal nerve at the fibula neck. There are 3 places it can be stretched. And the issue is that if you're worried, you're better off releasing the nerve than actually worry about it. When to release the nerve, there is no guidelines, there is no rule, and there's nobody can predict. We need to look at it, individual patients, individual patient's soft tissue, how much correction we're going to do, and then do the release or not. It's all very personal thing. If there are any doubts, just release it. Is as simple as that. Then the second question comes in, how much you correct. And again, there is no guidelines. It depends what you're correcting, how far is the neurovascular structure. We correct a little bit, but some people have corrected more. And if it's a multiplanar correction, lengthening, then the suggestions is to correct less because the risk of neurovascular compromise can be there. So this is an example. It's principally femur, bit in tibia, and I did an acute correction, but I was worried, so I released the nerve. You can say, do you need to? Perhaps not, but I can sleep better because the deformity was quite significant. We perhaps could have got away with it because of the femur, but there's also the tibial deformity we were correcting with the frame. So we thought we better correct it. We better release it. What implants you use? Plates usually are not good for diaphysis, but metaphysis, they work pretty well, and nails are pretty good at the diaphysis. And again, it depends what you're going to do and a lot of other factors, what implants you're going to use. If you're doing a closing wedge osteotomy, that's quite straightforward. You put 2 wires, you put your hinge, you put 2 wires, and then you angle between the wires is your level of correction. You take the wedge out, correct it, and basically you get it straight. And the advantage is, since there's no translation, you end up, you can use, if you're correcting at the cora, then the osteotomy or all that you use the rule 1, the advantage is that whichever implant you want to use, you can use. Dome can be slightly tricky, and because we rotate at the cora, and therefore always there's a small amount of translation. It always uses the rule 2. There are ways to work around it, but in principle, we have to realize there's always would be translation. How much is the translation? That will depend what implant we use. So then where we put the pin? Well, that depends on what implant you're going to use. So let's say this example in the tibia. If you're going to use a nail, then you put your pins posteriorly here, posteriorly there, and then you can put your nail right from the right from here. Your nail will come in, it is well away from the from your nailing, from your reamers and the nail. If you're going to put a nail, the other thing what you can do is distally you can put either a very anterior, so well away from the your canal, or you can put it distal to the nail length. You don't have to put the long nails in it. You put a short nail and put the pins away from the nail, but you have to decide this preoperatively. And so this is quite critical. The preoperative planning is quite important. If you're using a plate, it's quite simple. You put the pins on opposite side and then put the plate on the open side. That's quite easy. In the femur, again, if you're putting in a nail, then put the pins posterior, and these are pins at the posterior. You see your canal is quite clear here. Then if you, and then once you correct it, so there's your nail, and you can put a nail. The important thing I must point out here is the entry point of the nail may not be a standard nailing point, entry point. So pre-planning is important, and I'll show you the example later on. You correct it, and then you decide where your entry point is. And again, if you're putting in a plate, then just put the pins on the opposite side, and there will be plenty of space for the plate to put in. If you're using an LRS, then you can plan according, because it doesn't have the option of a hinge and overcorrection. Well, you can do under and overcorrection with the LRS as well. So here you put in, you put your pin parallel to the joint. Then there is a hole which you could put 10 degrees to the this wire, and because the anatomical axis is about 10 degrees from the mechanical axis, and your correction is an anatomical axis. So you need to plan it that way. Once you put in a pin, correct it, and then put in a nail. And again, if you see, it is all planned where you can do osteotomy, how far is the nail, all that is planned. Preoperatively, you mark it on the patient, and once you do that, this is what you get, and this is your axis, and the bone is looking straight. So what options you have? You have hexapod assisted, which you can use. You have Ilizarov assisted. You can use the hinge, which is my principal thing. You can monolateral assisted, and I use quite a lot of these days. It's a unicortical assisted, and because it is something quite new, and because there's a torque limiter in it, so you just put your pins and it stops you automatically. Pins will only go that far, and because it's unicortical, you can put the pins very quickly. In about, we actually timed it. Within 12 to 15 minutes, you can put in a fixator, and that saves a considerable amount of time in it. But it works as a sort of a kind of LRS without the hinge in it. So the control can be slightly tricky. So that you have to think about it. And I'll show you an example in a minute. The principles are pretty much standard, whatever you do. Whichever device you use, it doesn't matter. You need to align each ring to the, or fixate to the respective segment, plan the osteotomy, correct it, check the long leg alignment, that's corrected how you want, and stabilize it. And this is an example where we have aligned each segment. This is the distal ring, this is the proximal ring, this is a correction, and each segment is aligned. If you see in this, and again, the same patient. So once we have aligned it, all you need to do is make the frame straight, and it will straighten the bone. So how do I do it? Just a quick mention. So this is the joint line. This is the distal end of the plate, just slightly proximal to the PCL attachment. This is where I'm going to do my osteotomy, and this is where my plate will finish. I'll try to put the pins at 8 hole because I'm planning to use a 6 hole plate, but just in case I have a problem, I can move the plate slightly proximal, so I have a bit more length. Once I'm marked on the in theater, I put in I have put my hinges. I use 2/3 rings in a way. I plan it in a way so all this area is open for me to put in the plate. I've got plenty of space. So I have access, and then all you have to do is fix it. So these are the 2 half pins on this side. On the lateral side, proximal to the 8 hole plate. This is a 2 half pins on the medial side. And these are the computer trackers. Here you can see these are the computer navigation trackers which I've placed, one on distal segment and one on the proximal segment. And so now we are ready. We have put in a fixator. We are ready to correct it. And the important thing we have done is we have aligned each segment to its respective segment. In this case, I did a closing wedge osteotomy, 2 wires, again put it through and do the osteotomy. Now, when you use a computer navigation, you will get something like this. So your screen will show there is a 16 degrees of varus in this patient, right? Overall, 16 degrees of varus in HKS in hip knee axis. And when I've corrected it, it is showing me 3 degrees of valgus, slightly overcorrected. So this is what I want. So I've looked through my diathermy method. I've looked through my computer navigation. I've ensured that all my numbers are correct. And then I lock it. Once I lock the hinges, all this is locked. And this is the big advantage, that once I have locked my hinge, front and back, my correction is stabilized. All I have to do is put in a plate, and still I'll put in a single screw distally, single screw proximally, and recheck my alignment, because sometimes it can move. And if there's any doubts, I just move one screw and then check it, and then I can correct it again. So I don't put the plate straight away. I put a single screw on each side, recheck it, and then I put on my plate, put on the remaining screws. This is the finished product, and this is the case. This is a different case. So this is correctors look straight. Now this is a different case for the X-ray. So there it is, a lateral compartment osteoarthritis, and there are a number of ways to correct your to check your axis. One is you can use a threaded rod, so center of the knee to the center of the ankle and to pass in the center of the knee, or you can do that use a diathermy method, center of the hip to the center of the ankle, and it passes the center of the knee or wherever you want it. So in this case, the axis I put in slightly medial. I wanted to overcorrect it. Now, normally we don't do that in that compartment. In this case, I wanted to overcorrect it. So this is where what the computer navigation shows. That is the 7 degrees of valgus in this patient, and the axis was 60% in the lateral compartment. And there's a bit of a hyperextension, which we're going to ignore. And once I've corrected it, I put in a slight varus and this is where my axis is, and now I'm in 30% in the medial compartment. So this is where I wanted to correct it. So I planned it, I've checked it, and then I logged my fixator, and then I put on a plate. So this is a pre-op, this is the post-op, this is the axis, and this is 30%, and this is where it is. So all that is, she's passed a 5-year post-surgery, corrected, looks fine, nothing, very happy. So these are the ways where you can look into it and correct the very accurate correction of your of the deformity and put the internal fixation. If you want to do a 2-level correction, this is an example of a 2-level correction. Here, this is an elderly lady, 80-year-old. She couldn't walk, and we have to, because she lost her independence, which is a big thing in our country, that patient, because she was living on her own, she wanted to continue living on her own. So she had a insufficiency of the medial collateral ligament. So we did a stress testing, checked for the adduction contractures, checked all that, and did a 2-level correction, planned the hinges, planned the osteotomies. This is in theater, and then put in a nail. Put in a nail, and then she was fine. She had a bit of a problem, or has arthritis started becoming problem, and so we took the nail out, put in a total knee replacement with a long stem, and actually long stem covered the both osteotomies. So it was after the healing. So we can do all that. It's quite easy now, because sometimes you have a problem with as here, if you see the nailing part jig can come and may have a problem, because we can't put it on because there's a frame here. So what you do is you do a suprapatellar nailing, and that gives you plenty of space, so don't have to worry about that. Then this is some example of a unico assisted example, and unico is a unicortical fixator. So all you do, so this is an example of that. This is a valgus in a quite heavy chap. This is the preoperative planning, and we also have a separate planning where we want to put a plate and where the fixator go with everything. Again, each one I will mark in theater, so know where we are going to do. Planned it, marked it. I did a dome osteotomy, and this is the dome, and this is the incision for this half pin, and this is an incision for the drill. So we did all the holes, but didn't connect it. Then put in a fixator, and here you can see it is a unicortical fixator. So you can put in wherever you want, and you can nail it. You don't have to plan the pins. This is the big advantage. So we put on the fixator, and then once I've corrected, did the dome. This is a slight translation, as you can see here. And then it's a kind of slightly free hand. We did the diathermy axis, the center of the hip, center of the knee, center of the ankle, and measured it on the table. Then you put in a long rod, hold it, lock it, double check it, and this is what you get. This is the preoperative axis, and this is the postoperative axis, all coming straight. So it's quite useful and quite simple, and you get pretty good accurate corrections with these. And these are the clinical pictures, pre-op, post-op, and the knee movements. Knee flexion, which is symmetrical to the other side. So again, what you do for plating, if you want to put the lateral plate, put the pins medial. If you want to put the lateral medial plate, put the pins laterally. It's quite simple. Nailing, put the pins posterior. If you're using unico, then you can put the unicortical pin. It really doesn't matter. And here, this is an example in presence of total hip replacement. I put in the pins, and they are not touching the stem. Here, I put in a pin, and I've nailed it with the pins on. So it's quite easily, you can do all the things with the fixator on. That's the biggest advantage. Then sometimes you can also do an oblique plane osteotomy. This is slightly challenging and more difficult. And in femur, it's relatively easy, because you just need to match the canal and do the job for you. And here, if you see, I've used a blocking screw, and my entry point is very lateral, if you can see here. And this is the important bit here, that what I mentioned earlier, that you need to pre-plan it, correct it, and check it. Where's your entry point? I was very worried that my nail will go here and my correction, I'll lose the correction. So you plan the polar screw and you plan your entry point, and this is important that you do this. Otherwise, you do the correction, and when you come out, your correction is not accurate because during your nail has moved and it hasn't gone where you wanted it to go. This is an example of a two-stage procedure. This is a young man. We needed an HTO, but he didn't want a frame because he wanted to go back to job. He was self-employed. He used to run his own company, and there's no work, no money. So he wanted the minimum possible time in the frame. So we just said that between 6 to 8 weeks. So he agreed for that. So this is my preoperative planning. How we're going to do, where I'm going to move my hinge onto the lateral tibial spine. Did that, put in a fixator. And if you see, the whole of this area are left without any fixator pins. All this is for the plate. So there's internal and external fixation will not be touching each other. And this is the postoperative picture after correction. And how I do it is, I put in a 5/8 and the 3/8 ring. And this 3/8 that I put on the medial side, right? And the reason for that is when you do that, you can take it out and put your plate. You got plenty of space. So here my 3/8 is here, so I can take it out anytime. This is a hexapod. I've corrected it, and my axis is quite where I wanted it here, and this is the area open. So what I do is I take a 3/8 out. Put the supporting thing up. We use a trauma strut, but you can use about 4 threaded rods. Doesn't really matter. Take the 3/8 out and put in a plate. And when you do that, you can put it while the fixator is on. Put all the screws. Take the fixator off. And in 4 weeks later, we put this on. And at 6 weeks, he was back at work. And this is a final picture when he's healed. So it is, he had 2 surgeries, but it gave him something what he wanted. The disadvantage, as I said, more surgical time. And sometimes there's a rebound phenomena, particularly in tibia. So if you're worried, then just do a double plating or think of a nail, because there can be sometimes an issue. And the biggest disadvantage of fixator-assisted internal fixation is you have one chance. If you don't get it right, that's all. There's no chance of it going back and you correcting it. And this is an example of a rebound phenomenon. So he didn't want fixator, so we said we'd put in a fixator-assisted internal plating. So I've left lateral side open, corrected it, and I thought since it's the opening side, it will hold it better for the rebound phenomenon. So this is the intraoperative access, and when I did a post-op, I've lost a bit of correction, and it has moved back. So I've corrected it, but from the pre-operative, but it's not as good as I really wanted, and it's disappointing. Patient is happy, but I think I could have done better than this. So if I have this like this now, I'll probably put a double plating. So to summarize, it is fantastic for the metaphysis because you can put any any implant, and it's much easier. The biggest thing I would say is the most important thing, the compatibility between your 2 devices. Whichever external fixation you're using, make sure it is compatible with your plate or nail jig, whatever you're using. Because if it comes in each other's way, then you put in a fixator and you can't put your internal fixation, because you can't put the jig, or because there's not enough space to put in your internal fixation, and that becomes quite challenging, and you have to modify it. It's not easy. You lose the correction, becomes very, very difficult. So pre-plan what implant you're going to use internal fixation, and check it that it is compatible. It does not come each other's way, and if it does, then you have to modify your external fixation. Leave enough space for your pin placement. As I showed you, that if you use a 6-hole plate, put in half pins away from the plate, so there's enough space to use a plate one size larger, or so they don't come in each other's way. It's quite important. So these are the two most critical things. If I would say, leave enough space for your implant and the compatibility of the internal and external fixation jigs. You must follow the principles of deformity correction, because this is important, and pre-planning is absolutely crucial. You know where the translation is, where your entry point of the nail is, do you want to put a blocking screw or not, and all the principles which you can think of has to be applied to get the accurate correction. Since you only have to do it once, because there's no other way, there's no chance you can go back and do it. So that's not an easy thing. So thank you very much, and for invitation, and invite you to the Hull Deformity course, which we run every year in June. So for first 3 days, for 3 days, it is the deformity planning, and the last day is subspecialty, which this year we are planning to free live telecast. So 10th of June would be live telecast, and we hope to go through OrthoTV hopefully and do it. I haven't spoken to them, but we should do that through YouTube. So join us on the 10th on a subspecialty day, because unfortunately the course this year is full, so I cannot take any more delegates. But for next year, if you want to come, please come. Thank you so much. Jayant, I can't hear you.
Hello. It was a mind-blowing lecture, and those who have missed, they'll miss something really great. Although they'll be having the access to it on the YouTube, because it's streaming and would be streamed later on also. Questions and any points to be raised, Manish, if you have any?
Sir, thank you so much. It really, as you said, sir, it was really mind-blowing, and I was completely glued to the screen. Though I will go back to YouTube and clear a few of my doubts. They're not really doubts, sir. Just want to revise them once many times, because there's some very important points. Sir, couple of things, maybe not directly linked to this. One is, as you mentioned, increased surgery time by a few minutes, and maybe a theoretical risk of increased chances of infection. So actually, have you encountered it in real practice, sir, or it actually is a theoretical thing, sir? That is one.
Manish, you're talking about the two-stage.
Yes, sir.
Method. Yes. No, I haven't actually, but it is well known that if the internal and external fixation device touch each other, the risk of infection increases, and that is one of the reasons. Lengthening over nailing has been discarded. Now we do lengthening and then nailing. So lengthening and nailing rather than lengthening over nailing. And the reason for that is because the infection risk was up to about 35% in some series. So now what we do is we make sure that internal and external fixation devices, you plan it in a way so don't touch each other. And so, I mean, in elective, I haven't had any infection, but in some Charcot cases, so what we do is we do the same thing for example, ankle fusion. So we correct it, fuse it, and we plan the fixator in a way, put the wires in the calcaneum posteriorly, and then after about 2-3 months, we nail it. So the fixator time to be reduced in the Charcot ankle fusion. And so there we have encountered one infection, but there's a risk. So the emphasis was that we must be careful. We might be lucky, but if we careful, then the luck would be even better, I think.
Right. And if I may ask another question, sir, this was regarding the valgus correction in a genu valgum at the distal femur. Sir, I have done a couple of cases. Some cases have ended up with that golf club deformity, sir, which is also well described. Sir, would you give me some tips? I mean, is this does this really make a difference in the long term? That is one. And with this technique, as you just described, are there chances that I may minimize that?
I think, see, one of the issues is that when we have the residual deformity or the golf club deformity, it how much is it that depends on what are the other conditions. So a lot of the times minor undercorrection, and you're not the only one. We all have done it. Whosoever has done surgery will have complications and problems. And I have quite a few patients where I undercorrected, and I cursed myself a lot of things, and I looked at it, why that happened. So we all learn from our mistakes. And so I think that will depend on a lot of things. I think one of the things we miss out is that, is there any deformity in the sagittal plane, and that is the true apex is in the oblique plane. And that is one of the things. So my suggestion would be that if we plan with the deformity and it's an oblique plane deformity, then all we have to do is just rotate the hinge slightly obliquely. And as long as you put the hinges at the apex of the deformity, then we'll be fine. It becomes much more difficult with the monolateral fixators.
Sir.
So that would be quite challenging. So therefore, it is easier to do with the hinge assisted, because we can place the hinge and we have a better control. Femur is relatively easy, because what we can do is, when we look at it on the table, and sometimes all you have to do is just manually do slightly and correct it. So there are ways, but we still end up doing, and I'm telling you all this, and I'm sure someday I will end up doing it as well.
Thank you, sir. Thank you very much.
Yeah. Okay, Siddharth has message that his internet is unstable. Neeraj sir, any questions in the chat box or YouTube or Facebook? I don't think so. Neeraj is there. So anytime have you faced a problem that when you put in the nail and then use the fixator, although you are using a unicortical fixator nowadays, previously when you were using a the normal fixator, any problem that through the holes of dynamization or locking holes, the pins have got stuck up? I mean,
you mean no? I mean, no, that I haven't. That problem I haven't had, because we take a lot of effort in sort of measuring the length, and that's the same thing we're going to put in, and we still leave a bit of a distance. If I have understood the question correctly, is this what you're asking, isn't it?
Yeah.
So no, we take a lot of effort and time. So a lot of time in theater goes in actually planning before we do anything. So how we put the fixator, the length, and the implant, what is available, we check everything, and then only we start. One of the common, one of the things I have got stuck is, which I haven't mentioned in this talk, is that when you correct the deformity, you might have impingement. So what I didn't mention, actually, I just realized I didn't put that slide, that before, so once you complete the osteotomy, if you think it's going to impinge, leave a bit of a rod, a threaded rod at the end, and lengthen about 1 centimeter, and then correct it. And actually it helps in osteotomy as well, that we have done the drill holes, and then tension the whole thing about 1 centimeter lengthening on the threaded rods. And then when you do the osteotomy, because it's in tension, the osteotomy is easier. And when you correct it, it doesn't impinge. So that's another tip which can be quite useful at times.
Okay. That's a question from Siddharth, I think so. what are those subset of patients where you would avoid lengthening and then nailing? I was says previously, read the previous question also as lengthening and then nailing.
So the question is that the set of patients where I will lengthen and then nail.
Yeah.
Sir, if my audio is clear, I'll try and ask the question.
Mm-hmm.
Yes. So I want to know what are those subset of patients where you would avoid this procedure, as you said, number one, and number two is are you using any biomarkers, or maybe do you have any criteria where you can predict those people who are at high risk for infection after lengthening and then nailing procedure?
So in femur, Siddharth, I think is relatively easy. The risk of infection is less, and to be honest, there are no clear predictors, and I think that's the reason pre-op assessment is quite important. So somebody with a previous infection or history is not very clear, I'll be slightly more careful. In femur, I'll still use the nail, but what I would do is I would either put in some stimulant, or I coat the nail with an antibiotic gel, hydrogel or something to decrease the risk of infection. But in femur, I will still use the nail. It's very rarely I won't use the nail. So any patient with preoperative history of infection, open fractures where they are not clear having infection or not, multiple procedures, I'll be a lot more careful. So those are the patients we need to be careful. And certainly if they are associated with comorbidities like immunocompromised, diabetes, then I'll be a bit more careful. In all these cases, I will also do a dome osteotomy. Actually, that's my preferred osteotomy, because although there's a slight translation as it rotates, but the bony contact is fantastic, it's very stable, and you can compress it really well and it holds well. So that's my default osteotomy. Now, in tibia, if I have any doubts, I'll go with the frame. And in foot and ankle infection, I would be very careful and avoid it. But sometimes in the Charcot patients with the fixator assisted deformity correction and the fusion, it's not always possible, but those are sort of separate subsets. So I won't talk about it. Now, as compared to biomarkers, no, I don't actually, because in the chronic osteomyelitis, biomarkers are not very useful. If you have any doubts, then I would use, in terms of prediction of infection, if you look at all the investigations, the combination of, I'll do an MRI scan if there is no metal. I'll do a contrast MRI. The second thing I would do is, the best predictor of potential infection would be 3/4 bone scan in conjunction with a white cell labeled scan. The sensitivity and the specificity as combined is the best of all the investigation. That includes the PET scan. Because PET scan, we don't know what we're looking at the minute actually. So these are the two best predictors in combination. If you have any doubts, I'll do those scans as well and then plan things. I hope I've talked a lot. I hope I've answered your question.
Yes, sir. That was a very, very lucid explanation. Thank you.
Okay. Any other question from audience, or otherwise we are also running short of time. It's already 9 o'clock. So I might be busy.
Thank you so much.
Okay, sir, we'll call it day. I mean, day for you, night for us.
So much. Yes,
thanks a lot, sir. Thanks.
And thank you so much for the invitation. Thanks a lot once again.
Thank you very much, sir.
Thanks, sir.
Thanks. Take care.
Thank
Good
you,
night.
sir.
Good evening, sir.